Okay, this is Average Joe here, and this is all about why do therapists do what they do. So that's what we're going to look at tonight. We're going to look at why do therapists do what they do. And we're specifically going to look at acute lumbar radicular pain. So we're going to look at that, and we're going to really get down into the nitty-gritty, get my little glasses on here, of why do therapists do what they do when it comes to treatments for back pain. You know, I had several videos here over this last, let's say, week, specifically talking about improvements in sleep with radicular pain, treatments for disc herniation. I just dropped a video this morning about sciatica and the how you technically floss. You know, you don't stretch the sciatic nerve, but you actually stretch the hamstrings in a nice supported position. So hopefully you guys will look at that one. So this first article. Let me get my pen here so I can mark things down. This first article here, this was by Spine Surgery. So this is more of a medical doctor, an MD. I'm a doctor of physical therapy, so a lot different. But this article really looked at non-steroidal anti-inflammatories, because I always talk about that in all my videos. If we're dealing with some sort of pain, I'm always telling you the 3 things to do. You're going to rest, you're going to ice, and you're going to do non-steroidal anti-inflammatories, are also known as NSAIDs. So whether it's Aleve, ibuprofen, naproxen, if the doctor puts you, non-steroid, puts you on an actual steroid packet, which could be dexamethasone, prednisone, some sort of zode, to try and get the inflammatory process to calm down. So here they looked at NSAIDs. They basically said here, first line of defense for acute lumbar radicular pain accompanied with a lumbar disc herniation. So that's what they're looking at here. And this was a study done overseas. It's an original article. This one is actually done spine surgery, like I said, and this is a 2018 study. And they're looking at certain chemicals and their effect against acute lumbar radicular pain. So we looked at here is they're looking at evaluate the efficacy and safety of this particular alternative to the NSAIDs. And so that's what they looked at here. They had 30 patients, and they looked over a 4 weeks period of time. And the results were 4 patients in the NSAID. So they had a group of people that were taking the non-steroidals, and then they had another group taking this new medication. And essentially what they came up with is after 4 weeks, they looked at, okay, 2 separate groups, and then they did one with both NSAIDs and this new medicine. So they compared it, and they essentially said having both the NSAIDs and the pregabalin is what this medicine is called, and they showed it as a greater improvement reduction in pain in 4 weeks than either just that pregabalin alone or just the NSAIDs alone. Now, the funny part here is with this particular study, when you think about, okay, well, what happens within 4 weeks? I always talk about where you're reducing the inflammatory process. So, you have that 3 days, 72 hours right there. That's just natural healing. So, there, unfortunately, since it's 4 weeks, and we're talking about a medication, comparing one to the other, then comparing them together, when we talk about reduction overall pain, the problem here is the length of time is your outlier. That maybe it's just sheerly the length of time that it took you to do the study is manipulating the overall results. So I'm certain there was probably essentially the study saying that, yeah, if you take both, it's better than taking one or the other. That's essentially what this study says. The study also looked at, this group was between the ages of 20 and 80 years old. So it was a large age group. I mean, someone in their 20s healing process is much, much faster. Talk about hormones, certain cells aren't the same. Obviously, something simple as the mitochondria aren't the same at 80 as it is at 20. Just your slow twitch and fast twitch muscle groups, you've lost a ton of that at 80 years old versus a 20-year-old who is just coming into the peak of those particular types of muscle fibers that I'm talking about. So this study is not that strong. So if I was to say to someone, oh yeah, let's go ahead and have you do both instead of one or the other, I think this study has just too many holes. This is really a Swiss cheese study, even though it's coming from a credible source. It's a peer-reviewed journal. It's a fairly new one. It's within the last 5 years. So this was the years of 2018 and 2019. So it is relevant when it comes to timeline. It's the study's not so old that it's just completely not relevant anymore. This was a random control trial study, so it wasn't like it showed up. So, I mean, they had, when it comes to the power of the study, it has some significance to it. Though, like I said, we're going to rate the average Joe of 1 to 5, 5 being amazing, 1 being a kind of a dud. I'm going to give this a 2. I'm going to give this a 2 for a couple reasons. One, it was over a 4-week period of time. It had enough people in the study. It had 30 people in the study. So that it wasn't 3,000 people like I've had in other studies, but it's significant enough. But like I told you, it had all these other other Swiss cheese holes in it. So that's why I'm giving, I give it a 3 or 4 if maybe, it had more patients in it. Maybe it was for, a smaller group in regards to age group. So you're at least taking out that factor of, hey, maybe it was an age-related healing process that's going on. It had absolutely nothing to do with NSAIDs or this other new medication that they're talking about here. So I'll give you the conclusion of what they said. In conclusion, the combination of NSAIDs plus they acronymed it as PGB is more effective against sleep disturbance than NSAIDs. Alone in patients with acute lumbar disc herniation, although adverse events occurred more frequently in the NSAIDs, like stomach ulcers, bleeds, usually that's the case, and that's what happened here. The percentage of such cases necessitating the discontinuation of the treatment due to severe adverse effects was only 10%. So it was a small group of people that couldn't tolerate the medication, suggesting that this combination of therapy could be an acceptable option for conservative treatment for acute lumbar disc herniation. So unfortunately, this was all about sleeping and with these 2 medications and in pain. So if I would have said, hey, yeah, my sleep study, or I said, hey, these 4 different positions with a problem with your back, hey, you also are going to want to do this piece too, I would definitely say no. Obviously, the anti-inflammatories I always tell you to do, but this is a dud. So that's a dud when it comes to sleep. So that's a real stinker, but oh well. Better luck with this next one. So this next one is all about get my words right here, right? Molecular brain. There we go. This study is from 2013. This is an old study. We're talking 10 years, so we're going to see if this stuff really would relate today or not. The title of the study, Analysis of Sleep Disorders Under Pain Using an Apogenic Tool, possibly involving of the activation of the dorsal reified nucleus serogenetic neurons. That's a mouthful. So what they're basically saying here is they're looking at certain neurons that will affect sleep. And if they somehow have a tool to maybe either measure this particular neuron, and does that relate to sleep? So that's the first piece of this. So there's a background here. Several etiology reports have shown that chronic pain significant interference with sleep, right? No duh. We all know chronic pain will reduce his sleep. Inadequate sleep due to chronic pain may be contribute to stressful negative consequences of living with pain, right? Captain Obvious here, right, people? However, the neurophysiological mechanism by which chronic pain affects sleep arousal pattern is yet unknown. So, all right, they know pain, person's in pain. They know that it's affecting their sleep. They're trying to figure out the neurophysiological. What's the neurons? Is there a certain neuron that is activated with pain, and that neuron is affecting sleep? That's what they're looking at. And is there a tool really to measure that? So that's interesting, because if you can have a tool to measure that specific neuron is directly activated when there's pain, and that neuron is directly correlated to, maybe even causation to, the lack of sleep and pain. So, because correlation and causation, they sound the same, but they're two different things. Okay. So, they're looking at serotonin levels. And they're looking at was proposed to be responsible for sleep regulation, whether the activity of H2 generic, yeah, no, my words are too generic. H2 geric neurons in the dorsal raphe nucleus. They were nice enough to break this down into DRN. It's affected by chronic pain, has been studied only infrequently. On the other hand, the recent development of epigenetic tools has provided a valuable opportunity to regulate the activity in genetically targeted neural population. So really what they're saying is, okay, we got these new tools, and let's see if they do anything. So they looked at sleep. They looked at this tool. This tool was fairly significant. They had a sham, and then they had people with it, and then they had a pre, and they had a post. So they looked at the effects of sciatic nerves with ligation on thermal hypogeusia. So what they did is they took rats, they actually tied a cord around the sciatic nerve, so they strangled that, right? Ligation, fancy word for strangle. And they looked at the sham and with it, see what that neuron and tool does, and then they did it without it in the sham and see what that tool did. So the results. So the sciatic nerve ligation caused a marked decrease in the latency of paw withdrawal in response to thermal stimuli, only on the ipsilateral side. So on the same side. Why they don't say same side? That's Latin for you. With this experiment model for neuropathic pain, we investigated the changes in sleep patterns. So looked at the frontal cortical activity and postural muscle tone as monitored with EEG. So they monitored the EEG to see how their sleep and their wake cycle is. And then they looked at rapid eye movement, and they looked at sciatic nerve ligation. I keep saying litigation, I apologize. For 7 days was associated with statistically significant increase in wakefulness versus the sham. So big surprise, right? If you go ahead and you artificially strangle that nerve, that sciatic nerve in rats, they're not going to sleep very well. Anything that can respond to pain, which is alive, is going to tolerate this very long. So they figured that piece out. If you put something in pain, it ain't going to sleep. No doubt, right? So what they did now, so they looked at determining whether the neural activation in that particular neuron is necessary for interfering with sleep. We tested the effect of long-term optical stimulation of this particular neuron on the wake-sleep cycle And then they found out, and this is through mice, like I said, showed an increase in wakefulness. So they did no stimuli and with the stimuli. So they did it with the neuron being choked, with the sciatic nerve being choked and without the sciatic nerve being choked. Discussion here. Sciatic nerve constriction was previously reported to induce poor sleep quality in rats. Okay, yeah, no duh, right? These findings suggest that the neuropathic pain induced by peripheral injury may lead to development of insomnia. People probably knew that already, but they needed to do this test, right? We injected these mice with a certain PFC. What is PFC here? What did they shoot them with? PFC is in A. What is PFC here? Flora gold labeled cells following a microinjection in the PFC. Okay, so there was an injection in the PFC. It wasn't that, it was the chemical. All right. So that's that piece of it. So they, these poor mice, they really took a beating for us, didn't they? So after the investigation of looking at the cells in the brain, this particular neuron, and they revealed the population basically of these poor little rats. So they go ahead and they cut them open afterwards. Warning, this gets gross. They look at the brain stem and see exactly, did they notice any change between the two rats, one with the sham and one without the sham. So, results on this one. We produced a sciatic nerve ligation model by tying a tight ligature around the proximal 1/3 of half of the sciatic nerve. So I already talked about that. The key finding of the present study was that the levels of this neuron released in the PFC, which is part of the brain, by electrical stimulation of that neuron was significantly increased in mice with sciatic ligation. Using opogenic tools in mice, we found a causal relationship among the neuron firing cortical activity and sleep to wake transition. In particularly the activation of that particular neuron produced a significant increase in wakefulness and a significant decrease in REM sleep. The duration of REM sleep episodes was significantly decreased during photostimulation in these mice. So in conclusion, these results can suggest that the neuropathic pain accelerates the activity of these neurons. Although further loss of function experiments are required, we hypothesize that this activation of this neuron may, at least in part, correlate with sleep dysregulation under neuropathic pain. So they're saying that essentially that this neuron, and who knows, it could be more than one neuron, but at least one neuron among what? Millions upon millions, right? So, I mean, who gives a hoot, right? Well, it does give you a good idea of it isn't just, hey, I'm in pain, I can't sleep, and they're like, well, it's all in your head. The pain has no relationship to sleep. Well, anecdotally, we already knew that, but this here gives you facts that yes, when we're looking at the lack of sleep, these neurons are actually being affected by pain. So chemically turning into structural. So after they dissected the mice and they looked at the brain, they're like, holy cow, they look different from the ones that did not ever get stimulated with pain. And so, neuron, how this goes with pain, you have a chemical response, then you have an electrical response, and then amazingly enough, it turned into a structural change in the brainstem of these mice when you're having chronic pain for long periods of time. So it's not only affecting your sleep, but it's also affecting your brain. So that's only one study. I mean, you need to do a lot more, but it definitely starts to give you an idea, starts opening up doors, new hypotheses of holy cow. People just like, yeah, you just take this or take that and your pain's less. So they need to do some studies into, okay, what happens if you're on some sort of pain reliever or you're in some sort of, Michael Jackson sleeping agent, propofol, and they're under pain like this. Does the brainstem stay the same? Does it keep the brain structure normal, or does it not matter with if you're on some NSAIDs or propofol or opiates or something like that? That would be a nice study to do. So this episode really just the do's and don'ts of therapy, and obviously we want to keep you out of pain as much as possible. It's the fifth vital sign. And keeping you out of pain and hopefully getting you to sleep correctly. So that's why I did that video on sleeping positions to help reduce pain, as well as the stretching the muscles around the sciatic nerve and flossing the sciatic nerve and putting your body in certain supported protected positions to do the exercise the safest in the most correct way. So that's really the last two videos. If you guys have any questions, hopefully you'll give me a DM and give me a chance to hopefully inspire you guys and give you some information. So that's this episode. And until next time, Scully and I always like to say, look up and keep smiling. See you next time, folks.